Welcome to session 3 of day 3 of Rhythm Interventions Online 2023. In this session, the focus is on ablation of paroxysmal atrial fibrillation using a single catheter solution. Joining us for this session, we have Melanie Gunavardine from Hamburg, Germany, and two fellow Rio Coast co-directors, Julian Chun from Frankfurt and Jason Andrade from Vancouver. In this session, we're going to look at a case that was recently recorded at my center, St. Bernard's Medical Center in Jonesboro, Arkansas. Before we start, we have a poll for our audience. Let's have the poll, please. So the question is, what would be your preferred workflow for PVI or PVI plus in the event that, let's say cost is not an issue? Multi-electrode HD mapping and point-by-point RF ablation, cryoballoon ablation, or pulse field ablation, say with and without separate mapping catheter, or a single shot integrated map and ablate pulse field system. So please vote now, and we'll come back to the results of the poll later on somewhere through the session. So I'll take this moment to thank our panelists who have stuck around with us and go on to presenting this case that we did at St. Bernard's Medical Center. So just a little background on just the globe system as such. You can see there all the variations of point-by-point catheter here, balloon catheter, high-density mapping catheter, or a PFA catheter that's able to ablate. But the idea of the globe system is that it's able to bring all of this together, including high-density mapping, giving us the option of a single-shot PVI with pulse field ablation and also atrial ablation if need be. Can you advance that slide for me, please? Thank you. So the system as such is a 30 millimeter array that, let me just go back there, sorry. And if you can play that video, that'd be great. It's a 30 millimeter array that has about 122 electrodes. Each of these electrodes are about 3 to 4 millimeters and about 1 to 2 millimeters apart from each other. It is introduced through a 16 French sheet. That's the inner diameter of the sheet. Each of these electrodes is able to map, it's able to pace, and it's also able to ablate. You can get 3D mapping of the atrium and also navigation on both the globe array as well as get a three-dimensional map if you need to. You can also get contact assessment, which we'll discuss in a minute. Voltage and activation mapping is another feature as well that you can get both on the 3D map as well as on your globe. The system allows you to do pulse field ablation as a single shot technique, or where you can just do PVI, or you can go to a PVI plus strategy if you wanted to and address the posterior wall, the mitral line, or any other substrate that you identify. Would you update the next slide, please? Thank you. So there are two ways that the system measures contact. And if you look at on the left side, what you're seeing is what's called the flow map. And on the right side, what you're seeing is a contact map. Both the flow and the contact maps measure contact using temperature sensors that are behind each of the electrodes. And so if on the left, what you see is the flow map, which measures the differences in the rate of cooling in these electrodes and then decides whether you have contact. And it's a way to do real-time navigation and rapid mapping as you're moving the globe array around the left atrium. Now, the contact map, which is on the right side, measures differences in the rate of heating. So it delivers a subthreshold stimulus and measures that rate of heating and assesses contact in that way. And so that takes a few seconds, but it is more accurate, and that's what allows us to use a more precise lesion placement before we do the pulse ablation. Here's an example of what the maps look like. On the left, you can see the atrial map, which is a 3D anatomical map that's usually generated within under 3 minutes. In my case, I'm actually doing a map and a blade simultaneous strategy. You can do either way. And on the right side, you can see the globe map, which is the map on the array itself, which gives real-time data on activation, voltage, and contact as you're moving that array around. And regarding just delivering the therapy, the catheter is very flexible. The sheath has bidirectional deflection. So you can actually position the catheter in different configurations along the pulmonary veins and have a very precise single application of pulse field energy by selecting those electrodes. So the green highlighted areas are the electrodes that are selected for those precise application of the PF energy. So let's go on to the patient that is being presented today. Is an 80-year-old male with paroxysmal atrial fibrillation, normal ejection fraction, a reasonable left atrium, who was unable to tolerate sotalol and was referred to the PVI and was enrolled in the Pulsar study that that's currently ongoing in the U.S. So here you can see we are starting the procedure. We're getting ready for transeptal. In this case, I've used fluoroscopy to demonstrate some of the features of the array. There are times where we actually don't use fluoroscopy or pretty much have very minimal fluoroscopy. But here I have a VersaCross wire in the superior vena cava. I'm coming with a VersaCross sheet, getting across into the left atrium. I think with the globe array being a 31 millimeter array, it is important to make sure that you have a good transeptal, ideally somewhere in the anterior location, so you have room to maneuver the array more posteriorly into the right veins when the time comes. But here I'm trying to go into a more anterior low-mid approach. So not quite inferior, but kind of in the low-mid area. So once I'm across with the VersaCross wire, I'll park my loop wire, or you can use a amplified stiff wire. And you can park it in the left superior pulmonary vein, and you can see that on ICE. My ICE images are from the left atrium, to be very clear. Shows you the left superior pulmonary vein and the ridge between the appendage and the pulmonary vein. And once I park the wire in there, we're now getting ready to come with the sheath. And you can see me kind of slowly moving that sheath forward. It's a very easy transition between the dilator and the sheath. And once I have the dilator across, you can see me loosening up the stopcock and moving just the sheath over the dilator, and deflecting it down. The little blue knob is a deflection handle, kind of deflecting that sheath down to kind of the mid-atrial location, just making sure that, my sheath is in a safe position. And you can clearly see on the ICE that the sheath is nice and mid-atrial, kind of pointing a little bit more posteriorly, which is where we want it to be as we're getting ready to bring the array back in. So currently, I'm getting ready to take the dilator out and getting ready to bring the array in. And I think it's a very ergonomic handle. If you ask me, I usually use my left hand to deflect the sheath and use the right handle to maneuver the array most of the time. And here we're getting ready to get the array connected. You can see on the camera, I'm attaching the array to the sheath. And it's a very secure connection. So it's and they have great valve systems that allow or prevent any kind of air ingress as you're putting it in. So here we're getting ready to deploy the array. And if you look on fluoroscopy and on ICE, you'll see I bring the array to the tip of the sheath, and then I'll slowly unsheath and move the array forward simultaneously, making sure that on my ICE, I'm more posterior, so not entangling into the mitral valve or anything. And as you see, the array comes out, and once we see that kind of that proximal shaft electrode, we know the array is completely out. And then there is a knob on the array delivery system that allows you to deploy the array. So as you turn it on fluoroscopy and on ICE, you'll see the array come into its globe kind configuration. So here we're getting ready to kind of deploy the array there, and you can see the 31 millimeter array that is being deployed in the mid left atrial chamber. So at this point, we are maintaining a ACT of above 350, like any of our AF ablations. If you can continue playing that video, that'd be great. So here we are getting ready to navigate to the left inferior pulmonary vein here. So once the array is ready, I'm moving the array into the left inferior pulmonary vein. Usually I'll go into the left superior. In this case, we kind of landed on the left inferior. And you can see I started off with the flow map, and now I'm assessing contact with the contact map. And the blue shows me that I have great contact around the left inferior pulmonary vein. On the left, you can see the voltage. I pause and I select my electrodes. And the way you select the electrodes, you can select the electrodes that have contact to tissue. It's a very precise selection. And then you add additional electrodes to make a valid bipolar ablation path. And it's okay to add electrodes that are not in contact with the tissue to create that nice bipolar ablation path. So here we are selecting the electrodes. You can see it on the globe. You can see it on the 3D map, and you can see it on the array that is being shown in the bottom as well. And at this point, we're getting ready to deliver pulse field ablation. Here we start the pulse field ablation. And this is an optimized pulse that we are using in the PulseSolve trial, which was what was studied, and it comes from the Pulse EU study. So here we are using the optimized pulse. And once we do the pulse, we'll move on to we'll check contact again, and we'll move on to the left superior pulmonary vein. So we're moving on to the left superior pulmonary vein here. I'm assessing the flow map, which is the green, and then we assess the contact map. You can see the left superior pulmonary vein there. We will check, and I'll make sure on my 3D map on the left upper corner that I have good overlap. I'm looking on my globe to make sure my electrode selection allows for good overlap between the left inferior and the left superior, that I'm covering the carina, and that I'm not going too anterior or too posterior. And then I'm ready to deliver that pulse field. Again, it's that single pulse strain. The pulse is bipolar and biphasic. And once we deliver that pulse, again, it's about I would say 30 to 40 seconds for that whole delivery. I'm holding on to the catheter as it's happening. And in our case, we are using general anesthesia. We have a great cardiac anesthesia support, so we use cardiac anesthesia for all our cases. And in this case, we're using general anesthesia. And then I confirm that I continue to have that contact. So once I've delivered the pulse, I'll confirm that again. So here we're getting ready to navigate into the right side. So I'll make the catheter neutral, rotate it. You can see my delivery handle on the camera. It's now upside down, which tells me I've turned that way, and I'm using my deflection. It's a bidirectional deflection. I'm moving towards the right superior. There's a beautiful contact map of the right superior there, showing nice antral coverage of that right superior. You can see the voltage on the left as well. And at this point, we go back to selecting the electrodes again. Again, making sure when I do that on my 3D map on that left upper corner, I'll make sure that I'm not leaving a narrow corridor in the posterior wall, especially in a small atrium like we're dealing with today. So you have that flexibility of selecting the electrodes and making sure that you still have a nice wide antral coverage. I'm more generous towards the anterior wall on the right side as much as I'm to the posterior wall. So you have that flexibility. And once here, you can let's focus a second on the pulse field ablation. And as soon as I finish the pulse field ablation, I'll assess my contact again. So here we're coming off the pulse field, and then I'll go back and make sure I continue to have that contact. And you can see we confirm that we have contact again. And as long as we have contact again, and I knew that I was in the same position, I'll be ready to move on to the right inferior. So at this point, I'm deflecting a little further down, watching on my 3D as well as on my globe array. And here you can see the beautiful flow map of the right inferior. And this is why it's great as you're navigating to see that, and then you can have a more precise assessment of contact with your contact map. And the blue shows you that you have adequate contact around that right inferior pulmonary vein. You can see the voltage as well. And I'm looking on my 3D map to make sure I've adequate overlay and overlap to the right superior, covering that carina, covering the anterior wall, making sure my antrum is very well covered, and then getting ready to deliver that pulse field train. And again, the idea that every train that I'll deliver, for every ablation I do, I'll go back and confirm that what I started is where I ended. So how the contact looked before is how the contact needs to look after. And sometimes there are cases where if for some reason it moved or I wasn't studying, I've been holding it, then I know exactly where I started, and I can go back and give additional lesions by moving the array a little bit further. But in this case, we continue to maintain that contact, and it's a very stable array. It doesn't usually move a whole lot, so it's very rare that we see that the pre and the post are different. And now here we're getting ready to do some post-ablation voltage map. And here I'm mainly using the flow map. I'm not really using the contact map. I'm using the flow map, and I'm using the voltage map on the globe to assess what my post-ablation or how my ablation looks like, and mainly to see how wide my antrum is, and looking at what my pre-ablation or what my contact map looked like, where my ablation lesions were tagged, and kind of correlating the two together to make sure that what I ablated is what I got. And it looks like we have a nice wide coverage in the left side. I'm looking along the antrum, moving the globe along the antrum, along the lines. And if you wanted to do entrance or exit block, you can actually put the globe in and pace from any one of those electrodes. So that's very advantageous as well. I think it's valuable, say, if you did have an arrhythmia or a atypical flutter that terminated, you could potentially use it to do activation map as well, including the voltage map in this case. So here you can see the post-voltage map, again, showing nice wide antral isolation of both the pulmonary veins in this case. I want to take a pause here before we go on to our next video clip and have some discussion with the panel on their thoughts on the system and the case as such. So I'll let Jason start from the top. Jason, I know you've had some familiarity with the system in the past with the RF system.
Yeah, I mean, I've done cases in the animal lab, both with the RF and with the PF. So we did a study, it was published maybe a year ago, for preclinical work, and then we've had it locally at our hospital with RF, and we did our first pulsar case with PF this past week as well. So there's a learning curve with the catheter, just because it doesn't necessarily have the same feeling as what we're used to. It's nice in the sense that you don't have to focus so much on being coaxial with the veins, because you're able to treat the whole way around the catheter. And so really it's about ensuring that part of the catheter can give you that optimal position. And the unique natures of the system, like having the flow maps and being able to see the ostium of the vein directly on the catheter and then plan your lesions in a very dynamic manner, gives you a lot more flexibility than you would with other systems. So I think it's a very different handling. It's a different focus when you're going through the procedure. But once you take the time to learn the nuance of the system, it offers a lot more flexibility than maybe it first seems.
I totally agree. I think, I would say about 30% of my cases are cryoballoon cases. And I thought it would be very similar. There is some similarities, but it is a different learning curve to this array than a balloon, because you're really not occluding. There's no force. It's a very different learning curve for sure. Julian.
Yeah, congratulations to this great show. It looks amazing. If this big balloon folds up inside of the heart, looks impressive. I was also wondering how about let's say the movement positioning, and both of you already answered some of my questions. If I remember well, you mentioned the size, the diameter was 31 millimeter of this device. So just it would be one question for me how to manipulate such a pretty large device if it was really blown up, and bring it down maybe to the right inferior vein. If this is a specific problem, this would be at least one theoretical concern from my end. And I think you answered already in part, since it's not over the wire, the system, and you're using GA, and probably you mentioned it is still very, very stable in its position, but this also would be one concern, or at least uncertainty from my perspective, if you can really keep a stable position. And the last point I just wanted to ask you is, it is a pretty large sheath still at this point in time. I think it was 16 French, which you mentioned as ID. So therefore, I think also it requires, of course, a super expert in order to safely manipulate such a device. And but it looks great having the opportunity, covering the full information, and also having the flow map, but also the contact map. I think there's I'm very curious to see how it works if you move on during the next clip.
Yeah, so just coming back to your first point there on the system and moving that 31 array around, you're right. I think it does give you flexibility because it's not over a wire. So there's some ease of manipulation because it's not over a wire. But also, I think that's where I feel like doing the transeptal at the right location makes a huge difference. Not going too posterior is, I think, a big, I think it's a key step, is to stay as anterior as possible with that, but also maybe stay a little bit mid, because you do have, number one, you do have bidirectional deflection on the sheath. So you can go both ways. The right inferior is what you would think is the most challenging with the balloon, or with the array. But when you are in the mid, kind of anterior mid location, and you kind of rotate it around to the right inferior, you don't really have to be coaxial with the right inferior vein. And so, as a person that uses like a cryo balloon, I'm always thinking, I have to be coaxial. Whereas with the array that has that has 122 electrodes in a 3-dimensional, 360-degree configuration, you don't have to be coaxial. So you can place the array in any configuration over that right inferior and just select the electrodes that's over the right inferior. So there's some nuances to it, but I think the beauty of the system is that you have 122 electrodes around this 360-degree globe, and you just have to be over the vein, which it was very intriguing to me when I first used the system, for sure. Does that make sense with what I mentioned? Now, regarding the contact, I think it's a great point, right? So the advantage for me of an over-the-wire system is you can have forward force, and you can confirm that you're staying in contact through the ablation. The ablation sequence is very short. It's 30 to 40 seconds of holding your hand still. As I said, I use GA, and I paralyze the patient because I want to be as streamlined as possible. I have the capability of doing it. Now, do you need it? I don't think so. You could potentially do it without GA and paralytics, but I do it just because I have the option, and I'm spoiled enough with a great team of cardiac anesthesiologists. But the fact that I think that is the reason why I think it's important to check your contact map before the lesion set and right after the lesion set, and to make sure that they are identical. And in 30 seconds, if it's not moved, it's very unlikely that you didn't maintain stability. And for whatever reason, if you did move, you can always deliver another 30-second different lesion set.
So one thing to add to Julian's point is So you were mentioned about the inferior vein, and if you think about the handling of it, it's similar to cryo in the sense that most of your manipulation is going to be within the sheath, right? So you get your deflection, you'll get your torque with the sheath, but the balloon is not straight on the end of the shaft. The balloon is hinged. And so by having that hinge, it allows you to kind of sideways into veins. And so as you're coming around to the right inferior, because it has kind of an angle at the wrist of the balloon, it allows you to rock into the inferior in a very, in much easier way than you think it would be. And so you have a stiff structure, not a sort of a conformable balloon. But by having that ability to kind of angle it around the corner, you can sit it nicely. And so because it sits and it's mapping continuously, you can see the flow mapping, you can see the orifice of the vein, you can get a voltage map, you can confirm all the things that Debbie's mentioned before you go on to ablation. You can run your contact assessment, and once that's done, you go on to your ablation. And with PF, it's very quick. And even, on this catheter, RF was also very quick. And then you can reassess that afterwards. And, immediately you can have a post-ablation voltage map right after your lesion. You know that the signals are gone because you can see the majority of the signals in real time disappear. And so it's a very active structure. It's not relying on some other mapping catheter somewhere else. You're getting real-time contact assessment, real-time voltage, real-time electrograms as you go on to ablation and come off. And so the workflow becomes a bit more straightforward because it's all done within the same catheter.
Melanie, you've had a lot of experience with pulse field technology. So how excited are you about this?
First of all, congratulations, Debbie. Very impressive case. I think everything that has been said, I totally agree on it. Just from my feeling, it's not very intuitive as an electrophysiologist in the first beginning to actually understand the whole movement of the catheter, because you don't really advance veins, like you don't go in them and out of them. And, so this is a little bit, I think, different also from a perspective to how do you check the veins? Are the electrograms gone? And also a question that I had, do you see any gaps? And also the catheter is rather large. And I know we talked about the movement, but I wasn't sure, like, the transeptal puncture position, does it play an important role? You said, like, during the case that you did it a bit more anteriorly. Is that because the device is so large and you have problems moving it when you go to the right inferior vein? And also another question I had, was there any PV reconnection that you've seen? Because as Jason and Trada just said, we see that all the electrograms are immediately gone when we use PFA. And this is good and bad. Like, we are happy very easily. But on the other side, we know that they can reconnect after a while and we might miss it. And they won't be, like, the signals will be gone for a while until you can see them again.
Yeah, so they're great questions. So I'm going to take one question and then I'll move on to the next clip. And I think I'll answer the second with the clip. So regarding the transeptal, just back to that again, I think one of the things that we see with the transeptal, you definitely don't want to be too posterior, for sure, with your transeptal, because you do have to turn towards the right veins. And I think that's something that we see with most, I would say most of the balloon strategies. We try to stay more anterior with the balloon or with the a larger shot, single shot PFA catheter, or not single shot, I would say like the Farapulse catheter. We try to stay more anterior to allow for the bigger catheter to stay or move towards the inferior part. The mid and the whether you come low on the septum or mid on the septum really depends on how large the atrium is, at least in my mind. If it's a smaller atrium, I try to go a little more mid, mainly because I want to have room to open the array in the mid chamber. I want to have move to manipulate the array. Usually any movement from the left veins to the right veins is in a neutral position. So we there's room to move this around. And then, and that's pretty much how I think about the transeptal. So I'm going to take this moment to kind of go on to the next clip, and maybe that'll answer about redos and reconnections and things like that. So I'll move that along there. All right, so I wanted to take a minute to show a different case here to just highlight the flexibility of the system. So this is a case of a left common. I'm not going through all of the steps, just the flow map here. You can see we are seeing the flow map, we're seeing that common. And I went on to doing the contact map, and I'm focused. What I decided to do is do a segmental ablation of this left common. And so I'm focusing my contact on the superior aspect of the left common. And you can see on the top maps are on the 3D, on the globe. And at the bottom, you can see the electrode selection. And here we deliver we confirm contact, and we ablate, and then we come back, confirm that contact again. And now I just kind of deflect that down to have better contact on the inferior aspect of that common. And you know, on the globe, it looks like that's great electrical contact. And then on the 3D map, it shows me my overlap with my initial lesion. So making it a nice wide antral lesion around that common. Now, could you do it as a single lesion? You probably could. I mean, there's some limitations on how many electrodes you can choose, or the path that you choose. But I think you could. But I like to have a nice wide antral ablation, so I chose 2 segments. Here we're moving that same catheter back to the right side. Now this is a small atrium, so you can see once I went to the right side, if you focus on the bottom right map, you can see I can see both the right superior and the right inferior on the globe simultaneously. And you could choose to ablate all of them at the same time, but I decided to do it one at a time. So I'm actually selecting the electrodes around the right inferior first. I want to focus a lot more on that inferior aspect of the right inferior. Again, giving it that nice wide antrum. You can see the idea is to make sure that you select a nice ablation path of that allows you to get a good overlap of signals. And then I check my contact again, but then I can see while I'm checking my contact, I already have the right superior. And I go ahead and select the electrodes for the right superior, making sure I have adequate contact with the previous lesion set to make sure I have, again, I'm not leaving gaps in the carina. And I think that's one of the things is you can clearly see where you have contact, what electrodes you have selected. If your contact is, say, if you have a much wider carina, you could technically do a second, you can do your superior vein and your inferior vein, and then come back and just put the globe right at the center of that carina and just do a strip along just the carina. And to me, when I look at, say, a balloon, a cryoballoon, I do segmental ablation with the cryoballoon all the time. But the thing is, you can't control where the lesion's going to go. I mean, you're going to get the carina, but you're also going to get more than the carina. Whereas with this, you have very much, you have the versatility of the flexibility of selecting the electrodes. So you know exactly what you're going to ablate, hopefully, with where at the point that you're selecting. So to answer just your question on the what else can you ablate? So on the left here, you're seeing just those locations on mapped out on a CT and the map on a PVI case. And on the right, the same globe can be moved over to, again, it's not over a wire. It doesn't have a nub. So you can actually just position it over the posterior wall and select those electrodes along the posterior wall and get a good posterior wall ablation as well, and posterior wall isolation as well. Again, mapping and ablating at the same time. Julian, did you have a question? I saw you raise.
Yeah, may I ask you one question? Coming back to the nice picture where you showed the orientation and organization of the electrodes. And as far as I could see, it appeared that the distance and the size of the electrodes is not equally distributed. So it appears to be a little smaller electrodes, and maybe depending on the orientation of the electrode and at a certain specific site, does it play a role, the distance, and with regards to your, or with regards to quality of lesions, or is it all the same because it is such a great PF lesion? It doesn't matter anyway.
So I would say that the electrodes do vary from 3 to 4 millimeters. So it's not that big of a difference, and they're about 1 to 2 millimeters apart. And at least my understanding is that there is not a whole lot of difference. But I'm going to have ask Jason, because he's done most of the animal work on this catheter, so he probably has more insight on that matter. So I'll pull in Jason on this.
Well, I haven't done most of the work. I've done some, but I mean, the electrodes in the projection that you see are distorted. It's not truly that different. If you look at, the actual catheter itself, the electrodes are fairly similar in size. It's just that the way it presents the information to the user, there's various ways that we can see it. When they do a flat map versus a reconstruction of the globe versus the projections, there's different visualization techniques. So I wouldn't worry too much about the electrodes being different relative to each other, because they're pretty homogeneous across the catheter. Just to get to a point Melanie had raised earlier. So they've done remapping studies. Vivek Reddy and the group out of Prague have looked at that, and they've shown, it looks like Devi's got it right there anyway. So maybe I don't need to answer it. Essentially, it is very durable with the tuned PFA algorithm.
Yeah, I'll go over the Pulsar EU study that Vivek actually presented at the AF Symposium last year. So the total data set reported covered about 59 patients. 48 of these patients were treated with what's the optimized pulse, which is what you actually saw during the 2 cases that I showed you, which is a pulse that we're using in the Pulsar study. So of these 48 patients, there were there were all of the patients had PVI done. About 14 of these patients also had posterior wall isolation done. So and of these 48, 38 of these patients had the current hardware, which is the 4th generation of the hardware, if that's of any interest. But if you look at this acute and durable PVI results, these are from the 48 patients that had the optimized pulse. And all these patients had PVI. And 14 also had, as I said, posterior wall isolation. And when you look at the remap data, 19 of these patients had remapping done. And you can see the durability of the remapping on the right-hand corner there. And most, you can see most of them had especially the posterior wall had 3 patients, but still 100% durability in those 3 patients, and about 95% durability in the PVI, which is 1 vein had reconnection in this data set. Now, more patients have had remap since then, but I don't think that data has been reported yet. Now, regarding the safety of the system, there were really no major adverse events that were reported in all of the 59 patients. You can see there was 1 episode of pericarditis, which was drug responsive, but no PV stenosis, no phrenic nerve palsy, or no fistulas, no vascular complications. And I want to just bring that back because I know Julian brought up the point of how this is a 16 French ID sheath. And so, yes, it is a large bore sheath. So the things obviously that we worry about at any kind of vascular injury. Now, I'm very paranoid. I use ultrasound for all my access. And I use pre-closure with Perclose for all of these. So again, I think those are things that I think we have to be diligent about when we use large bore sheaths. And the second thing is air embolism, especially with the large bore sheath. Obviously, in my case, we were using general anesthesia and paralytic, so there's not as much worry about, the patient actually taking a deep breath while the sheath is in and worrying about air embolism. But also to the point of the sheath as such, I think they have a great mechanism with the valves where it does have almost like a double valve in a sense that prevents air ingress. So you have the opportunity to kind of lock the system and open the system when you need it. So you're not really, I wasn't as worried about air ingress. Of course, I was very, very careful with my, I would say, air hygiene techniques, making sure that I aspirate and flush and all that stuff. So, but definitely no major adverse events that were noted in the Pulse EU study. Specifically, a note on the esophagus. All the esophageal scopes were negative. They actually went in and assessed the esophagus after in these patients, and very low rate, about 5% rate of SCEs noted on MRI. Now, just a point on the Pulsar study, which is currently ongoing. It is a dual cohort study that has two parts to it. The paroxysmal part, which is that I just showed you. That's the reason why we just did the PVI alone in those cases. We will soon be starting the persistent part, where we will be doing PVI plus in that cohort. It's a single arm study that has 400 patients, 200 in each cohort, so 200 in paroxysmal, 200 in the persistent arm. Up to 25 sites in the US, Canada, and Europe. And the first patient was treated in March of 2023, and US enrollment started in 2023. We've actually finished our paroxysmal cohort at our center, and 50% or so of the paroxysmal cohort is already been enrolled. So I'll come back to the panel at this point to take any kind of final questions. Let's make some comments on the study. And Melanie, does that answer some of the questions that you had?
Yes, it did. Thank you very much. I really appreciate it. I actually have one maybe provocative question. I saw that you showed the study that Vivek presented, and there was one pericarditis. And one thing we saw after all the PFA cases with Farapulse were that the patients actually do well after the procedure. They don't complain about any chest pain usually. And it's really something we noticed. They feel like nothing has been done. And now you're saying that there has been a pericarditis. And I was just wondering if it's like, true tissue specific. Do those symptoms occur, or was it like, because there was no tamponade, obviously. So I was a bit curious about that.
So I don't know the specifics to the case, but I will tell you that I've had over 20 to some patients in the Pulsar study, and we've had similar experience with with like what you mentioned, where patients really, except for the fact that they feel some pain in the groin from access, they don't really feel like I've done anything to them. So that's like my only proof that I've actually done an ablation. So that's been our experience. So I'm not quite sure what the specifics of that particular patient was in Vivek's study. So again, we'll have to see. I don't know whether Jason knows the answer to that question.
No, I don't know the answer.
Yeah,
maybe just
I will say that it seems tissue specific. I mean, we do labs after the ablation as well. Just I've not really had to treat any kind of pericarditis. Usually, after RF ablations, it's very common for us to give our patients NSAIDs and even sometimes colchicine and such. But in the PFA cases, we've almost universally avoided any kind of analgesia.
Just one comment from my side. I agree with Melanie, but I do not fully agree with her. But because it's not this, at least in our experience, not 100% wouldn't feel anything. It appears to be a lower rate of patient complaints, especially if compared to cryo, which typically have this while inspiration, some discomfort. But some patients still feel something, at least in our experience. And to best of my knowledge, I think also in Advent, there was a pericarditis reported. So therefore, I think we need to learn a little more also on this topic. But with regards to pericarditis and maybe blanking period, Debbie, have you observed any or zero blanking period recurrences with that device and these apparently very good lesions?
So it is, I would say it is early. Probably maybe half of my patients have gone through the blanking period so far. We just literally finished our paroxysmal cohort enrollment maybe a couple of weeks ago. So some of them are still fresh, but so far so good. So.
Yeah, because we found, at least this is our impression, and we hopefully will report on this, that patients with PFA or after PFA, of course, also do run into some cases of early recurrences. However, those without early recurrence, which is the majority, they do pretty well afterwards. So therefore, it is something intriguing also, at least from PF's observations. And I was curious how your device would work.
But also, I think, I mean, there's tissue damage and there is inflammation. So I think there's a reason why there can still be early recurrences. But I'm sure you will bring out some data on this.
Yeah, well, let's see. I mean, we do see troponin rises that are slight, like you mentioned. There's tissue damage, but the obvious discomfort that patients, you have to. There's also the fact when I say they don't require post-op analgesia, I mean they don't go home with anything. You also have
Another
to understand
question.
that patients under sure they are getting something by my CRNA who is not telling me what they're giving them, which I don't ask them either. So. But I'm sure interprocedurally they're getting something. But what I meant is they don't go home or they don't call back. We've not seen any of those instances. I'm sure they get some analgesics through the procedure for sure.
David, do you see or get to see a lot of vagal responses during PF ablation with this device, or is it similar to what we recently discussed also for the monopolar ablation and maybe different waveforms whatsoever with a FARA device in which we do not typically see it? But as to my understanding, it's also bipolar ablation.
That's right. This is a bipolar biphasic ablation. So I haven't. I'm assuming I just assumed we would get a vagal response, and we actually pre-treated all the patients with atropine. I did not bother to take a chance. These were, we didn't have a lot of catheters in the heart, other than we would have one catheter for just a map stability, usually a CS catheter. Sometimes I'll actually put it in the hepatic vein. Just, if it is easier, I'll just put them in the hepatic vein, or I'll put it in the CS. But I almost all the cases universally pre-treated with about 0.5 milligram of atropine, just to cover for any vagal responses. Jason, any thoughts on that matter? Have you seen?
Yeah, so I was just thinking as you were talking, so we didn't pre-treat and we had a quite profound vagal response. So like a long pause of about 10 seconds before it came back. So it can happen. We also saw, we didn't have paralytics on board, so we saw a reasonable amount of muscle stimulation with it. If you had them paralyzed, that might be a different circumstance, but without paralytics, we observed that as well. So something else to consider.
I have another question, maybe. It's okay. So you just said that there was no silent lesions or really low rate. And as you also use isolate, Debbie, do you see any microbubbles during the ablation when you ablate?
You actually do. I'm not sure whether you actually saw that on the ice as you're delivering the pulse field. You'll see the microbubbles, and I have to say that I haven't. Obviously, my experience with pulse field has only been in the clinical trials. I've had the chance to use this catheter, the FARAPulse catheter, and the FARA catheter, and the VariPulse catheter, and I have not seen a single one of them not show that same microbubble formation as I'm delivering the pulse. What has your experience been? Like I always put my ice catheter in the LA, so it's always more pronounced what I see. Everything's more clear because the ice is in the LA. So I almost always see it. But I'm just curious. I know you guys don't use a lot of ice, so you don't see it. And I always say what you don't see, you don't see. But we almost always see that with all the technologies.
Maybe if I also may ask you one other question. The beauty of the system also lies, of course, in the fact that you combine 3D mapping and ablation. And to what I could imagine, that the device also could play a potential role not only for PVI, but do more than PVI. And do you also have experience or for instance, like detecting low voltage areas, ablating those low voltage areas, maybe with linear lesions, not just like the plain ablation on the posterior along the posterior wall, but more, let's say, an anterior line or any other lines. I assume it works nicely, but I would be interested in this.
Yeah, so I'll take that question in two parts. I'll start by saying that that my experience, or I was only allowed to use the device in the paroxysmal cohort of the Pulsar study, which is PVI only. For the globe can only be used for PVI only, and so I pretty much had to use it just for that part. But having said that, for the persistent cohort that's coming up, I am looking forward to using the catheter in a more versatile fashion, whether as a full footprint of the globe and the posterior wall, or and to me, I'm hoping that in my persistent population, I might have a patient that has an atypical flutter that I can actually do voltage and activation mapping with the globe, and maybe select my linear line on the globe. So I'm hoping to do that, but I know it's been done, and probably Jason has more on that. But I do want to kind of touch base on the low voltage areas. So that's kind of one of my pet peeves when I do PVI and antral, and I decide the antrum based on kind of the voltage sometimes. So even in the paroxysmal cohort, as much as I try to, they're technically phenotypically paroxysmal in a way. By the time you map the atrium, you wonder how they are even paroxysmal sometimes. Like the voltage in the left atrium, there's so much more atrial myopathy than you expected. So we did have actually 2 patients that in the trial, at least, again, this is our experience, that actually had more atrial myopathy than what we expected in a paroxysmal patient. And we actually did our antral substrate or antral electrode selection to accommodate a lot more, I would say, the low voltage areas, and made it more of a segmental PVI rather than just 2 lesions in each of the veins. I went and did a more carinal lesion and a more, if I remember, it was a more roof lesion along the superior vein, and in the right veins, in one of the cases was more in the anterior septum. We had a lot of kind of substrate in that anterior septum, so moving that globe a little more, tilting that globe a little bit more anteriorly, and taking care of that substrate. So I think it does give you the flexibility and versatility to create. Obviously, a linear lesion on a globe is as linear as it gets, so it depends on, so I think the fact that you can actually overlay those lesion tags onto your 3D map helps you make sure that you are not having gaps. So you can move the globe and kind of create maybe 1 big line or 2 small lines, in a way, I would think. Does that kind of answer your question?
Yeah, thanks.
Yeah, I mean,
Jason,
just
what is your
to
experience in the animal lab, maybe?
well, yeah, in the animal lab, we did PVI with PFRF, combined PFRF. We also did linear lesions. We also did focal ablation. So all of it is selectable and programmable. So you can imagine that if you do your PVI, you can take the globe and just sit it on the roof. You can see where that is on your 3D reconstruction, like your typical electroanatomic map. You can also use your local activation patterns across the globe, see how it's activating, and then draw your line on whatever electrodes you want to use. And so it's easy enough to do that. You have voltage assessment, you have activation mapping in real time, and then you can also apply that to your shell that you create with your 3D map. So there's a lot of flexibility in the catheter in terms of how you want to use it to deliver the lesion set that you think is best for the patient.
Yeah. So I'm not, I guess we have to wait till the paroxysmal cohort finishes for us to go into the PVI plus. So, Richard made a statement, I think it was yesterday or on the day 1, that with great power comes great responsibility. And I'm going to have to remember that with technologies that we're seeing. I think in these 3 days, we've seen an array of pulse field technologies, and I think there's no limit to what we can do. But I think as EPs, I think it's upon us to make sure that we use it right, and it doesn't become a device that we just go and put in ablate. But I think it has its beauty, but it also comes with great responsibility on us to make sure that we do it the right way. I know we're kind of coming to the end of the session, so I'll just start with Melanie. Maybe some closing remarks on just this technology, but also your experience on pulse field ablation and where you see the future of AF ablation.
Thank you very much. So I think that for me, PFA is really the future, and it's a revolution in our field. We have now a specific tool that we can apply to the myocardium without any safety issues regarding the esophagus or the nerves. So very specific to the tissue. And I think if I have a patient that I can treat and I know that he's going to be safe, there's not going to be a complication that's going to maybe kill my patient, then I think this is already a very revolutionary step. I think in regards to efficacy, there still needs to be data that needs to prove that it's maybe even better in the future. At this time, it's non-inferior. And I think this is already a very good start because it's the first generation of all those systems. And there's still a lot of work that needs to be done. And I'm very excited to see the future of pulse field ablation.
Julian?
Yeah, I also agree, of course, on the very big safety promise of PFA as an energy source. Still, of course, we need to better understand the biophysics. We need to understand the waveforms, etc., which is individual and specific for each, let's say, design of a device. The specific device we have seen today, I think it is very, very interesting because it is, as you put it, it is it can map, it can pace, it can ablate, it can measure contact or gives us some ideas. So therefore, there's a big potential, I feel. Still, of course, versatility is still a topic because we still need to learn how could we use it, or can we use it on the right side maybe, or in the right atrium. This is something which, of course, remains open. But in general, I think it is very exciting. We are in exciting times.
Jason.
One of the things that I think is amazing overall, and I think this is a credit to the Rio program on the whole, is that, as we sit here across these 3 days, we see so many different technologies, so many novel approaches to dealing with the problems that we have. And we kind of talked about this yesterday in the left atrial appendage exclusion sessions, but the same thing applies here as we go through the catheter ablation sessions, right? So we have the tools that we've always used, and then we have things like the globe catheter, which is a little bit out of left field in the sense that it's, totally different from what we use. It's totally different in terms of its handling. The way we interpret the data during the procedure is not the way we would, say, be used to doing it. But by being so different, it's offering a completely different approach to what we do and a whole lot of novel techniques and novel insights to how to improve outcomes for our patients. So, this is another of the exciting technologies that we have available. It's a single catheter solution to do absolutely everything that we want to do in EP. It's kind of the mapping that you would want out of an Orion, but also giving you the ability to provide PF and RF ablation energies, tailoring it to the patient needs. So I think more tools in our armamentarium help us improve the outcomes for our patients, and it's an exciting time to be an EP.
Yeah, it truly is an exciting time to be an EP. I have to say, just today I'm just part of a clinical trial, and I'm thinking 5 years from now, which technology do you pull for what case, and how do you assess? And I think we still have so much to learn about atrial fibrillation. We talked about the technologies, but just the mechanism of atrial fibrillation, and where do we go from past PVI? Advent showed us that we're as good as as doing PVI, but beyond that, where do we go? And so I think there's a lot more for us to learn, not just in delivering technology, but knowing where these technologies can help us more. So it's been a fantastic session, and you guys have been a phenomenal panelist. And thank you for putting up with me through the hour, through our presentation and through our recorded case. So I want to just take a moment to thank Jason and Julian and Melanie for being here with me today and joining Rio. There's plenty more still to come on day 3 of Rio 2023. Next up, we have a symposium entitled SICD Best Practices to Predict Defibrillation Success. So stay tuned with us and keep sending us those questions. Thank you very much.